the bladder JAVELIN 100 trial is a randomized trial which we performed in bladder or urothelial cancer. Bladder cancer is the sixth most common cancer in the US and accounts for 200,000 deaths annually. First-line standard treatment is platinum-based chemotherapy. The problem with that is although most patients respond, relapse and resistance occurs, and actually survival is pretty short. Second-line therapy doesn't work that well. Second-line therapy is based around immune checkpoint inhibitors, and immune checkpoint inhibitors at that late stage are not as effective as we'd like them to be. And what the maintenance bladder trial does is it brings that second-line therapy all the way forward and sequences it directly after frontline chemotherapy. So instead of waiting for the cancer to come back and treating second line, you get frontline chemotherapy, and as soon as you finish the chemotherapy, instead of waiting for relapse to occur, you then give the avelumab at that point. And so that was the hypothesis, that earlier intervention directly after the chemotherapy, well, firstly, the chemotherapy gets control of the disease, which means it gives more time for immune therapy to work. And secondly, you're not waiting for the cancer to come back, in which case it's probably too late for many patients. So it's sort of a Goldilocks effect of not too early and not too late. That's the principle of what we did. It's a 700-patient randomized phase 3 study, metastatic urothelial cancer patients. They either have stable disease or responded to that frontline standard chemotherapy, and then they're randomized to either avelumab plus best supportive care or best supportive care alone. The primary endpoint was split between overall survival in the PD-L1 positive population and overall survival in the all-comer population. And after a median follow-up of 19 months, we showed a hazard ratio in the all-comer population of 0.69, with a median overall survival of 21 months for avelumab and 14 months for best supportive care. And we also showed in the PD-L1 positive population a hazard ratio survival favouring avelumab of 0.56. And again, landmark analysis showed really great results. So at that point, we then looked at other factors, so subgroup analysis, forest plot analysis, and we showed it didn't really seem to matter which type of chemotherapy you got or whether you had visceral metastasis or other factors, all seemed to benefit the avelumab arm. Progression-free survival benefited the avelumab arm. The toxicity signal was very much in line with what one would expect with the drug. We also looked at how many patients got on to get subsequent therapy, and we showed that the majority of patients in the best supportive care, 61% of patients in best supportive care, after progression went on to get subsequent therapy, which is a high proportion looking at historical controls in this environment. And the majority of patients indeed on best supportive care who progressed ended up getting immune checkpoint inhibitors. So overall, the study hit its primary endpoint, delaying progression-free survival in both the ITT and the PD-L1 positive population, working across broad subgroups of patients, well tolerated, and so therefore we think it's a practice-changing approach, which will be adopted to large groups of patients.